I don't know if my clock stopped or my connection is really slow, so maybe what we'll do just to make sure that that I feel like I'm connected to people, that we'll get going for tonight's event. First of all, I truly want to thank you for taking the time to join us tonight. I know that I had kind of forgotten, as a lot of people have, that it was a long weekend today. But I'm glad that you made time to be here with us tonight for this very important conversation. Tonight we're going to be discussing budget 2021 and the implications that it will have on the ability that we have as a province to support the protection and expansion of our public health. This past year has served to highlight the importance that a well-funded, well-resourced, and well-staffed healthcare has when dealing with the type of pandemic and health emergency that we continue to live through. Much like leadership and governance, budgets are a reflection of values and priorities that are held by those that aim to represent us. My name is Sandra Azokar, and I'm the Executive Director of Friends of Medicare. And behind the scenes, we have Alyssa Pretty, our Communications Director, who makes the organization of webinars such as this seem effortless. Today, we have the pleasure to be joined by two experts in the area of health policy and numbers. But before we get going, I would like to acknowledge that we are located on Treaty 6 territory and that we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant communities. So before we start, I want to keep in mind that Alberta's experience has been that the more we try to save money on healthcare by cutting corners and offloading to the private sector, the more problems that we have created in the long term. Over and over, we have seen that cuts to healthcare only compound the problems they profess to fix. With budgets, the devil is always in the details. Budgets, that as the one that we're going to be discussing today, was tabled on February 26th, but we're still waiting on the Alberta Health Services budget, where we get somewhat of a more clear understanding of where money is allocated or not allocated. That's one of the problems that we have, is that we never know. Sometimes Alberta Health Services becomes a black hole of where the money actually goes. So some of that, this discussion and a lot more will be discussed tonight. Just a few housekeeping before we start though with our panelists. I can't tell you where the washrooms are or where your snacks will be, but you know, hopefully while people are trickling in, you'll get that. What we will do tonight is we will first go to our panelists, and then we will have a questions and answer period. We encourage you to please put your questions into the question and answer icon that's right at the bottom of your screen, and leave the chats just for comments, because sometimes we miss the questions that are really important if you put them in the chat icon, under the chat icon. So we will try to get to as many questions as possible, and if we miss yours, we will make sure that we forward them to the appropriate panelists. So don't get discouraged if we don't have an opportunity to answer your question. So I'm going to pass it on to our panelists, because I don't want to take time from their presentations that they've prepared for us tonight. Our first panelist is Alejandro Pachon. Alejandro holds a BA in sociology from the National University in his native Colombia, as well as a BA in political science from the University of Alberta and an MA in public policy from the University of Ottawa. He was a doctoral candidate at Carleton University, but he left academia to put his research and analytical skills towards more practical purposes and to dedicate more time to social and political causes. And for that, we thank them. We thank him quite a bit. Alejandro was a policy analyst and an evaluator with the federal government for a few years, but after hiatus in Ottawa, he was happy to return to Alberta to work as a senior research officer for CUPE. In this position, he currently tracks labor market trends and policy developments at the provincial level. So I'll now turn it over to Alejandro. Thanks, Alejandro.
Awesome. Thank you. Let me just go ahead and open my presentation here. I am in the speaker mode already so that people can see the presentation. Yes?
Yes.
Awesome.
Yeah.
So, thank you, Sandra, for inviting me to talk about healthcare and the budget today. This is a thing that I track relatively close because, as Sandra mentioned, I work for QP, and healthcare is one of the sectors where we have a lot of members, and some of our members are being directly impacted by the policies and the budget that the government had designed. Uh, but I am here on a personal capacity. I'm not speaking in behalf of any organization. So it's like my analysis and my opinions about this thing, about the policies that I'm going to share with you. So it's kind of a Twitter disclaimer. My opinions are mine. And so I'm going to get into the budget right away because it's long and we don't have a lot of time. Uh, the first thing is I want to look at what the government is saying, right? Like we know, we have heard what the government said. It's a huge increase to the budget. It's a historical investment, and depending on who you hear, if it is Minister Chandru, is 900 million more than last year. If it is Kenny, is 1 billion more than last year. So this is what has been said about the budget and how was presented to the public. And I want to go into the numbers, and I want to go quickly through the numbers. And what I want to do is to talk a little bit about the budget itself, and then I want to talk a bit about how AHS and how the government, the healthcare department, plan to manage what is essentially a flat budget, right? So it's kind of two parts to the presentation. So let's get into the budget part first. This is what the numbers are in the budget, and I want you to notice a couple of things. One, for this graph, one is that we are just looking at the top of the bars, so we are not starting from zero, and so that is like so that we can look at where things are changing, that we can focus. The other thing is I have included 1 year that is not in the budget, but is from the previous budget, just for comparison with the last year of the NDP. And I want to say that I'm not going to talk about the capital plan side of the budget, mostly because there is no time. I am mostly going to be focused on program expenditure and operating expenditure. And so these are the numbers. There is a little, like, there is a bit, $1.2 billion that are here. And the idea of that money is that it can be spent in healthcare, but it can also be spent in other things, depending on what COVID requirements are. So I'm going to do the analysis without that part, but it may be that at the end of the year, because of that money, healthcare is like the COVID part of healthcare spending ends up being a little bit higher. So, but for now, we will move without that. And you can see that here is the 23 million that Chandru refers to. Compared with previous year as a total, it does not look like an increase, but that's a bit normal because we are coming out from a year where like the fight against COVID have been quite significant. So this is total program expense, but in the budget, the expense figure that you look at, it depends on what you include and you do not include. So program expense does not include capital investments, and it does not include debt servicing, but it does include other things that are not operating expense. So it includes operating expense, but it also includes things that the government already have and decides to use, like inventory. If you have a lot of masks in store, and you have this situation with COVID, and then you use a lot of that inventory, then that goes into the program expense, but it's not really operating expense. Things that you don't use because they expired, they are also counted there, like loss on disposal, and other things like amortization, capital grants. But this budget particularly also include in the program expense all the COVID expense for 1920 and 2021, but not for 21-22, right? So like there are 2 years that have the COVID expenditure included, And for the year that is starting, for which the government had the $1.2 billion, that figure does not include COVID. And so knowing that, we can go back to this graph and we can look at, okay, we can think, okay, so if we take out all that money, all the program expense that is, and the operating expense that is not COVID specific, how would that look? Just the operating expense that is, let's say, normal operating expense. And then we have a bit of a different situation here. You can see more clearly the extent of expense that have gone into COVID. I want to say that most of that expense has been funded by the federal government. The Canadian Center for Policy Alternatives calculates that about 93% of COVID expenditure in Alberta had been shouldered by the federal government. And in healthcare, there have been a few very noticeable initiatives, including the essential, the critical worker benefit, which was in large part, like mostly funded by the federal government. So I want to just focus on the operating expense, the normal operating expense. Like, so we exclude all those other things that I mentioned that are part of program expense, and then just focus on the operating expense to see what the long-term trend is. Then you can see in this graph that there was a bit of a decrease from the first to the second year of the UCP government, and then this year there is a bit of an increase, which is what Minister Chandro refers as the big 900 million increase. But just looking at that, you can see that the increase is not as big first, and that actually, in terms of the normal operating expenditure for the year that just ended, there was a bit of a cut of like something like $350 million. And that's, well, there were like some delayed surgeries, but there is also the result of a specific policies. So let me give you a couple of examples on this that explain the expected increase. One is the cut last year and the reestablishment this year of some physician compensation items, right? Like, so all the things about the complex modifiers that were in dispute, liability insurance. So if you compare the budgets, you will see the physician budget going down the first year, and then the physician budget going back up. So that's part of that will go into this increase that we are talking about, this increase here. There is another part, and it has to do with how, like, certain policies that the government adopted in the first year of government regarding drugs. So for instance, the government, like, drugs is one of the issues that one of the areas that grows faster in our healthcare system. So what the government did was to reduce eligibility. Specifically, they cut coverage for dependents of seniors, like wives or dependents, on the drug plan. So the drug plan for seniors, they cut coverage for dependents. So that created some savings. So like that cut in the service provision allowed the government to reduce the expenditure in that specific area. But this year there are new and more expensive drugs that have to be incorporated to treatment, so it goes back up. And partially, that cost was going to be offset by another policy that the government has in store, which is introducing income-tested deductibles for senior drug programs. So the idea of these income-tested deductibles is that less seniors will have coverage on their drug programs, and that would create the space to pay for, like, the more expensive drug treatments. So what the government did was cutting some specific programs, eligibility and some specific programs to offset the cost of more expensive drugs. And then that's another one of the things that explains that increase. And one third thing is a big increase on information technology, and I will have something more to say about that in a bit. But then what happens afterwards is that we have 3 years of a frozen budget. And this is the situation to which the system will have to respond, and I will try to talk a little bit about how the system plans to respond to that. But I want to say 2 more things about this budget, and the first is we know that federal transfers are going to increase over the next 4 years, over the next 3 years. The federal transfers, specifically the Canadian health transfer, will increase. And what I want to show you is like what happens if we just take those increases from federal transfers and put them on and add them to what the NDP spent in the last year of government. So here, so what happens is that by the end of this budget horizon, most of the increases that are forecast are paid for by federal transfers, right? Like you can see there in the last column, in the last bar here, that the amount of the increases in federal transfers is what is going to account for any increases in the healthcare budget. And these areas, these blue areas, they largely result from policies that the government has had to pause. I have mentioned the income-tested deductibles. So those are additional costs that the government had planned to cut, but is not going to cut right now because of the pandemic. And so those differences may reflect those pause policies. There are other things, and I will talk to them about those in a bit. The other thing that I want to say about this specific budget is like, if we look again at the total, the budget says in page 44 that there would be that population will increase and that inflation will increase. So they have a specific forecast for those 2 items. And so I just plugged those numbers and then recalculated this by person. So instead of looking at the operating expense in total, I look at the operating expense per Albertan. And this is assuming that there is neither population growth or inflation. But once you adjust for those things that are in the budget, like it's not something that I'm making up, but like that are in the budget, once you adjust for those items, the situation looks quite different. You can see that none of the historic investments that the government says they are making right now are going to have a higher real per capita spending in healthcare than under the last year of the NDP, right? So like there is going to be a decrease every year, and over time it would be about 9% in the operating expenditure that will be cut from the system. And this is according to the numbers provided in the budget itself. Now, what I want to talk a little bit about is how is this going to be accomplished? Well, this is like in general the conclusion of the numbers that I just showed you. There is a bit of an increase, mostly financed by the federal government, but in the long term, despite that nominal increase and despite increased transfers from the federal government, there is going to be a cut on real per Alberta spending in healthcare. And this is what I wanted to say about how are they going to do this? And page 100 of the budget says, we are going to implement many of the recommendations that we had from the review, from the AHS review. So this is a review that was contracted in 2020, and then the report was released in February, and in February 2020, and then the government said AHS has 3 months to implement this review. The review is a huge change to the system. And it's going to touch every aspect of the healthcare system. Um, I want to say, like, well, in general, there are 100 initiatives. The initial review had 78 initiatives, and then in the implementation plan that was supposed to be released in May of last year, and that was not released in May of last year, there were like some additional initiatives were put in. Some were added. The government devised that, AHS devised that in 5 areas. Each of those areas have specific recommendations that are attached to initiatives, and then they calculate how much money they are going to cut from the system implementing these initiatives, or how much money they expect to save implementing these initiatives. And this is a plan that was designed before COVID. The report was done, I think it was December of 2019, and then it was released in February of 2020, before the pandemic happened. But this is the plan that is moving forward, right? This is the plan that is that the government is going to implement to be able to do the savings, like the cuts. The AHS implementation review was released, like the process started even before the review had been released. If you look at the review, you'll see that in October, by the time when the government released the report, because it was leaked to the media, there were a number of initiatives are already undergoing, like they were already underway. And there was not public discussion about what what that was doing to the healthcare system. They were just implemented. And I'm looking at the time, and like very quickly, this is a graph that I think is really good, really important in that AHS implementation review report, and it tells you where things, like where the savings are going to come from. The most, like when this came out, people heard that it, like the jobs in things like laundry service, inpatient food, housekeeping, that all those things were going to be outsourced, and that about 11,000 public sector workers will be lose their jobs, and that captured most of the news cycle. But that was not the only thing. That's here in outsourcing. And so that's about, like, it's supposed to be about 11% of the savings, or like about $110 million. And these are estimates, and there are issues with these estimates. So I'm just gonna say what the report says here. But there are a few, like a number of other things that the government plans to implement in this area here of revenue cost and recovery. Sorry. There are some things that make sense. For instance, there is an initiative to reduce expense in utilities, but those things require investments, right? You want to pay less on utilities, you need to retrofit your buildings, you need to invest money. So like that is that like you may save $29 million, but you have to invest $108 million. And what is important to notice here is that those investments, including the information technology investment that I was referring to before, those have to come from somewhere, and the budget is going to be frozen. The biggest area, though, the biggest area for cuts is going to be workforce change. And that report says, like the report assumes that the commitments, job security commitments, will end in September 2020, so that the government can implement job layoffs as required. That's in page 20, and you can go and check the document. And the government had extended that, and the report says for every month that the government extend that, then we will be able to, we will not be able to save this amount of money. And so eventually, those are the things that reflect that are in the budget that show a little bit of increase. The government has paused some of these things, but they have not abandoned them. They still want to move ahead with this. They are cutting. We can talk a little bit about more, like with more detail about these things, but they are cutting nursing hours per patient. They are reducing some acute care beds. In fact, the only area of the budget that actually had cuts is acute care services, like nominal cuts, not just cuts by inflation, but nominal cuts. Acute care services will suffer some of those. And then there are like a number of other things. There is, especially in terms of cost recovery, they are proposing to increase fees in accommodation, in long-term care accommodation, increase fees for home care, increase fees in special accommodation in hospitals. These are like, this is supposed to bring Alberta in line with other provinces, but they expect to get about $140 million out of Albertans to replace costs that are like right now financed by the province. So like downloading some of those costs. So finally, like this is my last slide. There are like that report has some additional changes announced that we know are coming. The most important of those is a review of continuing care services. The government has finished a review of this. They are preparing a report. Like the contractors who are working on this are preparing a report. The report may be ready sometime this spring. And then there is the expectation that there will be legislation coming in the fall to reorganize the long-term care sector. And that may include what I have said about increasing fees or finding ways of downloading costs of the long-term care sector to seniors and to patients so that they can maintain a frozen bottom line. There are other things like the new virtual strategy. There is a lot of talk about having a lot more telesitting, things like bed alarms, other things that are to replace actual people taking care of patients. And that virtual strategy, it was said, was going to be released in December, but to my knowledge, it has not been released. It's something that I have been monitoring to see like when it comes out, what is it that is going to be in there? And there are some red flags because of the way in which the government had approached issues, like the applications, the Babylon applications, and other parts of this teleworking virtual strategy. So, and then there are new access and admission guidelines that have as the goal to reduce things like length of stay. And we can discuss a lot about what the indicators said on that. But the idea is that we need to discharge patients much faster in hospitals so that it's cheaper. And that is like these are some of the things that the government is planning to implement so that they can deal with increasing population, higher costs, especially of drugs, but also of other things, while maintaining a frozen budget. And this is a policy that was developed before COVID, but that is going to be implemented despite what COVID had taught us. So I'm going to stop there and let.
Perfect. Thank you so much, Alejandro. That's a lot to think about. When we decided to have this on April Fool's Day is because we believe that it kind of goes with the name. We don't want the UCP to fall as they, like Alejandro said, they made this as a historic investment. But what we see in Budget 2021 is just basically a blow to our public healthcare system in favor of privatization, in favor of cutting costs and putting those costs down to people that actually need healthcare. So a lot to think about. Our next speaker is Lorian Hardcastle. Lorian Hardcastle is an associate professor in the Faculty of Law and Department of Community Health Sciences in the Cumming School of Medicine at the University of Calgary. She's also a member of the One Health Consortium, O'Brien Institute for Public Health, and Conjoined Health Research Ethic Boards at the University of Calgary. Lorian's research interests include the regulation and governance of healthcare delivery, liability and accountability of health facilities and government, public health law and policy, and the self-regulation of health professionals. We're very fortunate to have Lorian with us today. She's been very busy in the media in the last few days, talking about the doctors' agreement, not so agreeable, but Lorian?
Thank you. You can see my slides?
Yes, we can.
Great. So, what I want to do is actually kind of pick off where Alejandro left off, which is with AHS, and specifically, I just want to highlight a couple of specific programs and maybe some of the concerns that I have with them. And these are some things that have been the subject of a lot of recent discussion and sort of press conferences with much fanfare. And so the first of those is the Alberta Surgical Initiative. And this is something that the government made an announcement on earlier, maybe in I guess early 2019 originally, I think, but just a few weeks ago, they announced that they're going to be accepting calls for proposals and really forging ahead with this surgical initiative. And their goal is to have 55,000 more surgeries in the coming fiscal year, in addition to getting up to pre-COVID rates. So obviously an ambitious goal. In terms of the funding for this initiative, there will be $120 million in operating funds in the next year, and then another $120 million in capital funding for over 3 years. Now, one thing that I was watching closely for in that capital funding is who are they funding? Because in the Saskatchewan version of this, there was actually public money that was infused not only into the public system, but into helping the operating costs and the capital costs of some of the private facilities. Now, what the government's website here, though, says is that they're going to expand capacity in AHS-owned facilities. So it appears right now that the intention isn't yet to sort of financially prop up the capital and operating costs of those chartered facilities. About those chartered facilities, though, so the chartered facilities, I'm sure many of you have read about them, but what the chartered facilities are privately run. So they're operated by private operators, but they're publicly funded surgeries. And these are very common for certain kinds of procedures. The main one is cataracts. Most cataracts, for example, in Calgary, are performed at these facilities that are not AHS facilities, but rather are run by private operators, but are paid for publicly. And the government's stated goal is to have, it was close to, I think they were aiming, although their target has been a bit of a moving target with COVID, but the originally announced target was that they wanted 30% of all surgeries in Alberta to be performed in these facilities. As I said before, it's been mainly cataracts up to this point, but the kind of surgery that they have in their sights to be doing in these facilities is orthopedic procedures. They've been in discussions with a number of orthopedic facilities. If you sort of dig around in the lobbying records, you can find lobbying efforts by groups headed by orthopedic surgeons. So that really does seem to be their target. Now, this quotation is not mine. I'm about to disagree with it, but what the government says about chartered facilities is that they offer safe, less complex, publicly funded surgeries, taking pressure off of hospitals to allow them to focus on the complex and emergency cases. The concern with these facilities, there's a number of them. It is true that they do less complex cases, but I wouldn't necessarily present that as a positive thing, because what can tend to happen, particularly with a finite number of health professionals, is that they take the less complex cases and those get treated right away because these facilities don't want the hard cases because they're expensive. And then people with complex medical needs can end up waiting longer in the public system to receive care. Certainly, this is something that other countries have experimented with extensively. And that tends to be what the international evidence shows, is that these facilities don't really take pressure off of the public system, and in fact can leave the public system scrambling for health human resources. And I think it's particularly going to be true here, where unlike the cataract surgery, some of what they're proposing doing in these facilities has much greater health human resource needs in terms of nursing and in terms of anesthesiology. You know, it's a lot more complex to sedate someone for a joint replacement, and they require a lot more nursing care than with, say, a cataract. So I think that there are those human resource questions, and we really haven't heard a lot from the government on how it plans to regulate any of this. How are they going to make sure that despite that that safety is maintained in these facilities, that patients with complex medical needs aren't waiting longer in the public system, and how are they going to ensure that these facilities don't tend to drive up costs, which they've done in the past? So that's one of the big pieces of the government's platform, and this is really a part of this desire they have to meet wait times targets, probably in anticipation of the next election. So a fair bit of funding announced for that initiative. Two other initiatives, one Alejandro has talked a little bit about, which was money for continuing care. And so just a few weeks ago in front of the hospital in Seton, you can see Premier Kenney there, was announcing $500 million in capital spending to create more continuing care spaces with community, nonprofit, and independent providers. The biggest issue I think I have here, I mean, I think we need an infusion of funds into continuing care as the population ages. And certainly there are patients that should be in continuing care, but instead wait for places in hospitals. They're waiting in hospital for a place to open in the community. So it's not that the funding is the concern. The biggest concern that I have here is where are those beds going to go, and what is it going to look like? Is it going to be mainly independent providers or for-profit facilities? Are they going to be publicly operated beds? Of course, we knew pre-COVID, but now we really know that there are safety and quality of care issues that arise in those for-profit facilities to a much greater extent than government on-run or publicly run facilities. So that's one of the concerns that I have. To link into what Alejandro said about continuing care legislation, one of the things that we've continually seen from this government is messaging around less regulation, less red tape. And I worry that the combination of more beds in the private sector, plus perhaps legislation that seeks to reduce regulatory obligations and reduce red tape, could be a significant quality of care issue in continuing care. It did mention also in the Ernst & Young report, although the government hasn't yet pursued this, but one of the things that was mentioned in the Ernst & Young report was AHS divesting itself of the publicly operated long-term care beds that it has right now. So there is a possibility to see a shift. There's already a lot of private beds in Alberta, but there's a possibility to see a shift more towards those private operators. And I would be worried about the quality of care aspect. The final initiative that we saw announced, big announcement over the last few weeks, was a CT and MRI Access Initiative. And they want to do about 50,000 more CT scans and up to 45,000 additional MRIs in the next year, which is obviously a lot. And they're spending $33 million to do that. One of the interesting things is that there hasn't been a lot of details on this initiative. When it was announced, I thought, my mind, of course, went to, contracts with private operators, or an initiative like Saskatchewan, where, Saskatchewan has embraced for-profit patient pay, 2-tier MRIs, and I wondered if they weren't going to do that here. But what it appears to be, having talked to some physicians who work in this area, is that those diagnostic facilities that exist in the public system are not currently working at full capacity. And so it seems that they've been sort of allowing spare capacity to exist, and they're just going to fund to fill up that capacity that was already there. In other words, this seems to be solving a problem of their own making. So that's that initiative, or that's at least what I'm hearing about that initiative. In terms of the physician services budget, this is from the contract that was rejected. The contract that was rejected proposed a $4.6 million capped physician services budget, and that number was for the next, was going to be, that 4.6 was going to be this year and next year, and then it was going to increase modestly after that. That budget, interestingly, would include both your traditional fee-for-service, you go to the doctor, they bill the government. But one of the concerns that I had with that budget was that it also includes things like Babylon. And so you have, on the one hand, Babylon advertising to you on TV, you should just go to the doctor all the time and phone up the doctor, and sort of driving up potentially unnecessary demand. And they're competing with your family doctor in that same finite pile of pot of money. So that was one concern I had with that budget. Similarly, physician services provided at those chartered surgical facilities would come out of this budget. And so one of the other things that this budget contract included, which was rejected, was budget management. And so what this meant was, if they forecast that the physician services costs would exceed the budget, then they would engage in this budget management process, which could include withholding payments to physicians for services that they provided. This happened in Ontario. It affected patient access to care. And so that was one of the issues in that contract. The contract also included, sort of in the category of crumbs that it threw to physicians to get them agree to what weren't great terms. It would have given them a one-time grant program funding of approximately $200 million for things like virtual care and those sorts of things. So again, this was the rejected budget. We're not sure where we'll end up, but this demonstrates some of the ways that the government is trying to control physician costs. So I want to move on and talk for a couple of minutes. I'm going to leave time for questions, but on the social determinants of health. So we've talked about AHS, we've talked about physicians, but of course, one of the things that can put pressure, particularly on AHS, is if we're not investing in the social determinants of health. If you're not giving people services in the community, then that can end up putting pressure on emergency departments, or it can end up putting pressure on the healthcare system in the future. Because of course we know that things like income and gender and housing and education are all factors that affect health. And so one of the things in the budget that was announced was $140 million over 4 years for mental health and addiction services. This sounds nice. But the main concern with this is how the government is spending that money. And, there have been scores and scores of op-eds and whatnot written on this issue. But the concern is the government's focus on a recovery-based approach, as opposed to an embrace of some of the harm reduction evidence that's very good, and their sort of rejection of things like supervised consumption. So the money is fine, but of course the way it's being spent is a problem. Another problem is that it doesn't address the cost of childcare. In the previous budget, there were significant cuts to childcare. The $25 a day daycare has now ended, and this disproportionately affects women who we know were already disproportionately affected by COVID. Some of you may have heard the word she-cession, which is a take on recession, with the idea that an investment in childcare is necessary to get women back into the workforce because they were disproportionately affected in terms of work because of COVID. For a number of programs, funding was merely maintained but not increased. So the Alberta Seniors Benefit, AISH, funding was roughly the same for those kinds of programs. But remember, simply maintaining funding is not really maintaining funding because of population growth, because of increased eligibility due to some of these programs because of COVID, due to inflation. And so even before this budget, there were concerns about AISH. And actually there were rumors that AISH was going to take a huge hit in this budget, and it didn't end up taking that huge hit, but certainly that rumor was there. So it seems that was at least on the table. This was in the previous budget, but we know that the previous budget had announced an intent to reduce the public sector by approximately 7.7%. That's been trucking along since the last budget, as Alejandro mentioned. This was part of the AHS Ernst & Young report, and they're wanting to outsource positions, and indeed there are calls for proposals out there to outsource some of those AHS services. And of course, the AHS jobs are unionized jobs with benefits and better working conditions. And when they get outsourced, people end up in a more precarious employment situation, sometimes less safe. And many of these workers are already migrant workers. Many are women, and so it's hitting those groups hard. We all know about the cuts to post-secondary education. They're huge, and their education is one of the social determinants of health. It also is going to affect income as a social determinant of health, because tuition is going to inevitably go up. You think I'd have an inside track working at the university. I do not know what the increase will be, but I know it's going to come, and it already has come. This isn't the first cut that universities have taken. There's also a per student K-12 students. The amount that schools get per student is going to be cut. And there's been no new funds announced to implement everybody's favorite curriculum either. Finally, I want to touch on housing. Mixed news for housing, although the good news is not that good. There was a 5% increase in operating funding for social housing units. When you take into account inflation and population growth, that's 5 is not a 5, it's more like a 3. On the flip side, there's a 6% cut to funding for capital maintenance for subsidized housing. There is an increase, $16 million in financial assistance to low-income houses who rent from landlords. However, this isn't really a funding increase. This is actually just restoring a previous cut. So it's not some generous increase. Finally, there were no major investments announced in the budget with respect to homelessness. And the housing issue is huge, because of course, with COVID, people's incomes have been hit really hard, and these housing issues are particularly challenging. And with respect to homelessness, certainly more people are homeless as a result of COVID, but also some of the shelters require additional funding to enable people to be able to social distance. So that lack of investment there, I think, is important in terms of those social determinants of health. So on a sort of final note, Alberta has categorized its own budget as protecting lives and livelihoods. The way that I would categorize their budget is that they've opted for a policy of low taxation, a lack of diversifying the economy, aggressive cuts to the public sector, and short-sighted choices that are unlikely to pay off in the long run. So that's how I would sum up the budget. So I'll leave it there so that we have some time for questions.
Thank you so much, Lorian. I think it brings clarity to quite a few of the issues that actually Friends of Medicare advocates on throughout the year, and that we continue to advocate seniors care being one of them. We know that 1,231 of the 1,994 COVID-related deaths have been people that live in our continuing care system, yet this government continues to fail to learn from many of those lessons that we have learned throughout the year. And it's incredibly frustrating that they are continuing just in their ideological path to privatize our public health care. So we're just going to go to a few questions that we have. I think this question can be put together because it talks to the potential savings that we've had through the year. We have a question that says, with COVID, we have had to cancel many surgeries. Was there a cost savings there? And then also we had fewer admissions due to people coming in later in their disease process. So do you see any of that reflected in the budget?
So I can answer that first. So when I mentioned that the physician contract had included $200 million of one-time funding to go into physician programs like virtual codes and what it was going to be used for was fuzzy. Virtual codes was as an example. but other kinds of physician grants and education and those sorts of things. That $200 million was alleged to be the cost savings from the physician services budget due to COVID. Given how hard hit many family doctors report being during COVID, and given that surgeries were canceled, there is a fair bit of skepticism that the actual amount saved in the physician services budget was $200 million. People think it was much more, but there isn't. The government hasn't produced data. So that's one place where the savings are showing up, I suppose. I don't know if you have anything to add, Alejandro.
I can say, just looking at the numbers in the budget, it's very hard to parse out what was the result of savings from surgery canceling and other services that were canceling, and the result of policies that were implemented by the government. Because the government has had already some things like Connect Care that are supposed to reduce costs. However, I can say that in the budget there is between the first year of the government and the second year, there was a decrease of $83 million in acute care, which is where surgeries happen. So it may be that 83 million reflect the fact that there were less surgeries, right? It may also be that there were specific initiatives that help reduce the cost of surgeries, or that help cut the cost of surgeries. And it's difficult to parse it out, but we can see that there is about $83 million in less money in acute care.
Perfect, thank you. We also have a question out there for either one of you. What is the connection between the UCP and TELUS? We know that they've been quite the good corporate company in terms of lobbying in the last couple of years. And so, yeah, any of you have any answers?
Yeah, I mean, there are some independent journalists that have tried to sort of draw the webs of the TELUS and the UCP and the UCP donors and the law firms the UCP likes to use, and it's all sort of a bizarre web. So certainly there do seem to be those connections, and people have tried to dig into them and look up who's donating to whom and what kinds of single source contracts are being sent to who. But sort of beyond, and there do seem to be connections. I'm not sure of the precise nature of them, but certainly it is a company that the government has, really has partnered with on a number of things. Another company like that is of course Ernst & Young, who continually gets contracts from the government. There's a few law firms that are of a similar nature, that they seem to get a lot of work from the government, more so than you would expect. And so they do certainly have some close relationships with certain companies and certain entities, and TELUS seems to be one of them. I think though with Babylon specifically, the thing about Babylon is, in some ways, I don't actually think Babylon is trying to get rich off of providing family doctor visits over the telephone. The thing that actually worries me the most with Babylon is the data issue. And if you look at the Babylon, the app, the interface, they want you to sync your Fitbit, they want you to do these assessments. And so I think TELUS's interest in the healthcare system is probably less healthcare and more health data. But again, the precise nature of the UCP connections elude me a little bit, but I do know that I've seen people try to map it out.
I think that this discussion, I have seen those issues with the power of lobbyists in specific policies. We saw that in Bill 204, when the government decided to eliminate, to allow for paid plasma donations, and that policy can be clearly traced back to lobbying efforts by specific companies. And so it is not there is a lot of lobbying that goes on, and the government seems beholden to these lobbyists in some of the decisions that they make. But I would like to put this discussion in more general terms in what is the virtual strategy that the government is going to release. We know that there is a virtual strategy coming up. It was announced in the AHS implementation review. And how that strategy is articulated is going to determine like a lot of how the province moves forward in that area of healthcare, including how it integrates applications, how it integrates telesitting and other like all other technologies for virtual care. And we have to like be on the lookout to see if those strategies are being determined by lobbying efforts, or like if they are in some way reflective of a specific interest. But I would like to look at that strategy, that thing that was announced as a whole, and look at where the government is moving in that area, because I have a number of concerns about what the strategy is going to be based, not only on the cases of what's happening with Babylon and with TELUS, and the extent to which they are going to influence that policy, but also in terms of how some of these things are supposed to replace actual people working in the system.
Yeah, and for sure. And one of, just to remind people that in 2018, TELUS actually purchased 30 boutique clinics across the country. I mean, they bought Copeman Healthcare. So if you live in Edmonton and you drive by 124th, what Copeman used to be, now it's called the TELUS Health Center. So not only are they setting up boutique clinics and blurring the line between private and public, but they're also getting the help from the Premier's office, who anytime that you write a letter to lets you know that this is one of your private options, that you can go into Babylon, and then Babylon directs you to all kinds of private clinics that they now own across the country: Horizon Occupational Health Solutions, Medicis, and Copeman. And so it's reflective, I think, of the direction that they would like to see our healthcare system go towards, and it's not by accident.
Just one more thing quickly about that. Like we know that as part of these things, there are also efforts to bring the gig economy into the healthcare sector. So like there are companies like Rivera that work in long-term care have made big investments on applications to hire people rather than to have facilities hiring people, so that they have a model of like, is what they call the Uberization of the healthcare. And this kind of strategies, the virtual part may play into that. And we know that it's not just TELUS. There may be other companies, including in the long-term care sector, that are pushing for these kinds of strategies. And that's
yeah. There's a question for Alejandro. Do you have any indication what the UCP plans will mean for negotiations with the healthcare workers? Do the numbers tell us anything concrete?
There are some things that are very concrete in the AHS review. They have said that they want to renegotiate the nurses contract. They said that they want to remove a number of provisions from that contract, reduce the coverage, for instance, for part-timers, like to reduce the number of benefits that part-timers will have, to change sick leave and other things. So we know that that part of the government is to cut staffing. The government strategy is to cut staffing cost by renegotiating this contract. There is a lot of talk about like zeros for like a number of years, and then there is the whole issue like for some other. It depends on the healthcare sector. Some workers that are in the areas that are going to be outsourced. That like those negotiations are going to be much more complicated, because it's not just about like wages, it's about like the existence of the job itself. And with like and there is no money in things like acute care. There is, like, as I said, acute care, like most of the areas in healthcare have a bit of an increase that reflects the bigger increase. Mostly like the increase is focused on drugs and physician compensation, but in the area of acute care is really flat. Like there is no increase, and because there is no increase in that area, it's really hard to see how that is going to translate in like wage increases of any kind, right? So it's going to be a fight, a big fight.
Thank you. There's another question here about delaying surgeries. guys believe that delaying surgeries create more costs as health issues are not addressed until they're more complex and severe?
Yeah, I think so. I think you know, when we put off either preventative care or we delay things, the ultimate costs can be higher. And I think that's one of the reasons that there is a push for a robust public healthcare system, and to actually bring more into the public healthcare system rather than what the government is trying to do, which is to push things out of the public healthcare system. And you know, you can use examples like, say, pharmaceuticals or dental, where we're putting off access to those things and making them privately paid for, you know, sends people to the emergency room and sort of costs more in the long run. And so I do think that putting off surgery can be the same. Can increase costs depending how the person's condition is affected, and sort of how many medical interventions are needed in the middle to kind of bridge them through till they get surgery. So I think there can be increased costs, but I also think, of course, there's a cost to the person themselves. We all know that there are psychological and sort of physical and pain related costs to waiting for surgery. And so I do think it's you know, so that the private system doesn't become a viable option. I think that we need to make sure that the public system is robust, and that we're trying to address wait times within the public system and find efficiencies in the public system, so that patients are waiting less time in the public system. But I don't think that the private system is a good solution to those wait lists. I think the solution is finding those efficiencies in the public system. And you'll often hear this government talk about the Saskatchewan Surgical Initiative, and how it was so great because, you know, there were these chartered facilities and they took the burden off the public system. If you read into that initiative, they actually did other things like centralizing waitlist management and doing things that we know help to improve waitlists. And so in that case, to me, that's the lesson to be learned from that initiative, not that we should farm out surgeries.
Sure, and I think that speaks to the wait times that was announced, the $33 million that was announced recently with respect to MRIs and CT scans. That money, if you recall, in March, the government basically canceled the contracts with 3 big private companies, MRI companies, diagnostic imaging, and they were supposed to apply for their jobs under an RFP. But now this government's gone even further and will be providing all that money to private MRI companies. So again, they presented it as having a plan, as Lorian was talking in the case of Saskatchewan. And this is not a plan. It's a plan that was already in place. So they're not really introducing anything innovative into the system, and actually undermining it even more by not accessing what we currently have in our own system. So not very much of a help. I'm going to just join 2 questions here that are pertain to the same issue. What part of the operating costs are strictly physician compensation? And did the AMA negotiations include the option of physician, and somebody moved my thing, physicians on salary?
If you look at the page 101, you'll see the operating expenditure disaggregated by area. So you will see physician compensation, acute care, drugs, and about $5.2 billion are allocated to physician compensation. Most of that is managed by Alberta Health, like so the minister, the department. But there is a little bit of that money that is managed by AHS. And that's what the difference is between the number in the contract that Professor Hardcastle was referring to, and the big number is that AHS has control over part of that physician money. But it's about 5.2 billion. It was 5 billion in 2020-21, and it will be 5.3 billion in 2021-22. Sorry. So that's it.
Perfect.
Well, with respect to the salary question, the physician compensation budget that was contemplated in the rejected agreement, but that even apart from the rejected agreement, the physician budget, it includes like traditional fee-for-service payments. It includes what are called alternate relationship plans, which are different kinds of ways of paying physicians, not fee-for-service. So there are different ways you can do this. You can do this by paying them based on the patient population they have, or based on the volume of patients they see, or the size of their patient group. So there's sort of different ways of doing that. But yeah, there certainly is discussion in Alberta of moving away from fee-for-service to other ways of paying physicians. There's some of that here. Other Canadian provinces have a lot more of that than we do. But yeah, that's a topic for discussion that continually certainly comes up both among physicians and among policymakers.
Thank you, Lorian. If the government's plan is fully implemented, what will be the per capita cost to the individual taxpayers? That's a really big question.
Like I haven't done that calculation. The initial like what the Ernst & Young said is like the savings were going to be $1.9 billion. Contractors always exaggerate these numbers, and for instance, in the surgical initiative, the chartered clinics, the contractor said we are going to save $60 million. When AHS went and did the math, they said, oh, it's going to be about $1.7 million, right? So it's like 95% less than what the contractor initially said. And some of the estimates in the AHS review, for instance, they have a high degree of uncertainty, right? And some of them are confidential to the minister because it's like they don't want the public to know these parts because that may affect bargaining and other things. So there is a high degree of uncertainty. There are certain parts that are obscure that cannot be seen. But like what AHS says is going to be about between 800 and $1.2 billion. But the actual numbers of that will be a thing to see. I like each of those they classify it as A, B, C, depending on the certainty that they have about these estimates, and a lot of those items are C, which means not very certain, right? So yeah, but I haven't done the division.
Perfect. I'm just going to join, and we just have time because we've gone over our allotted time, but I'm just going to join these two questions here. Have there been any studies on the cost in terms of overtime when there are staff cutbacks? I see this increasing for nurses in this person's local situation, and that what leverage do unions have to block policy from being enacted when it is an obvious attack on public health care? I guess the word general strike comes into mind, but
I'll answer the policy half, and I'll let you mull over the economic half while I do that. So I think, in terms of sort of blocking policy, certainly there are examples in the past of unions being effective, or physicians aren't a union, but we'll sort of refer to them as such. But with this government, they just don't seem to bend a lot in response to the demands of unions or the Alberta Medical Association. And even when public opinion gets involved and is behind these groups, this is a government that I think can be described as stubborn. All of the sort of cuts that they implemented with respect to physicians, there really wasn't a lot of ability to push back against those. They got a few changes to physician billings changed, and the minister sort of backpedaled on those. But this is not a government that is receptive to what either the public or unions says about almost anything. They really have a particular policy in mind and tend to sort of steamroll it through. And I think that's why Sandra's inclination was to say general strike, because they really don't seem very responsive to individual groups. And I think maybe closer to the election they might care more about public opinion.
I don't have much to add to this. there are parts, like we know that overtime cost may, like it may be expensive to have short staff, right? Like if you don't have enough staff and then you have to do overtime with the staff that you have, then you may end up paying more. I haven't had as much of an opportunity to look into this, like for instance, as the United Nurses Association have done. They have done a lot of work on the impact of those things on the nurses. But yeah, like in principle, like if you have too many, like if you are short staff all the time and you have to use the staff that you have, you end up not only with higher cost, but also with very extenuated people who are not 100% because of the like the burnout, and then you also end up in specific sets with settings with a higher degree of violence, for instance, among the patients. Like that's the case in long-term care, where like short staff has to work a lot, sometimes a lot of overtime, and then because seniors don't get enough care, then they end up being aggressive too, right? So like it creates a very difficult environment, which is not just, the cost of it is not just monetary, it's also the well-being of both the workers and the residents.
Thank you. Thank you so much. I have one last question that we have time for, and it actually kind of ties well with my closing statements. But before I do that, I just want to give the floor over to Lorian and Alejandro if they wish to give any message of hope, I guess. Lorian?
Hope. Well, maybe my message of hope is that as we, you know, every day you get closer to the election, the better behaved the government will become inevitably. That's sort of their MO. And so, you know, perhaps some of the deeper cuts are going to soon be behind us, and we can look forward to sort of receiving ridiculous money like we did under Ralph Klein that was sort of useless. But I mean, in all seriousness, I do think that they have front loaded the cuts into their mandate, and so hopefully there will be some sort of breathing room, especially as we start to recover from COVID, and that, you know, perhaps there can be some lobbying efforts around the next budget that maybe will sort of take the edge off of what they've done so far. That's as hopeful as I can be, Sandra.
Thank you. Alejandro?
I always tell people when I read these reports, a lot of the reports sometimes say that they are drafts, or that they are the initial proposal, and that things may change in the implementation, right? And I always say, like, well, let's make them change in the implementation, right? Let's some of the the AHS report, for instance, it says cooperation of the unions is going to be very important for the success of this. And so I say, well, let's not cooperate. It's always possible to change things and to force specific changes to government policy, but I think it requires that we are willing to participate, to remain informed, and to really work towards like a different kind of approach to healthcare in general.
Thank you so much, Alejandro. And again, thank you to both of you for sharing your evening with us. The final question that I wanted to actually put out was that what has Friends of Medicare made? Has Friends of Medicare made any further plans to mobilize public protests against government cuts and obvious motivations to privatize huge chunks on our public system? And while we don't have any plans right now, given the COVID situation, to go out en masse, we continue to urge people to join us, to share our news releases, to share everything that's out there in terms of bringing attention and education to as many people as possible, so that they can actually understand what is happening to our healthcare system. As Lorian says, they've put everything that they could potentially do earlier in their mandate, I guess with the hope that people will forget by the time that the election comes around. So it is up to us not to let people forget, because a lot of the damage that they have done through legislation, through all these studies that they have release will be fully in place by the time the new election comes around. So there is a lot of work that we will need to do, but we can't do that by ourselves. We need to expand our echo chamber and to get all these concerns out there to as many people as possible, because at the end of the day, budgets mean nothing. You know, the measure of a budget should not be some bogus measure of fiscal health that we will hear over and over again as we come out of this pandemic, but it rather, it has to be focused on how it will contribute to human health now and in the future. Behind all the stats, all the health policies and regulations, there are real people who depend on not having to worry if they can afford access to quality healthcare based on need and not on their ability to pay. So I guess that's our challenge, and that's where we need to be working towards. So thank you to each one of you for coming out. Alyssa will talk to our panelists to see if I know there's questions about whether or not these slides can be shared. We'll ask them. And there was one question, actually 2 questions that were left without answered. Don't worry, we'll send it to the right people so that they can be answered. And again, thank you so much. And I wish you a very safe weekend and enjoy your family as much as you can. Take care. Thank you so much.